Reducing the 30-day readmission rate for independent health Medicare members with admitting diagnoses of CHF and COPD by Jill Maline. In 2012, the Centers for Medicare and Medicaid Services initiated a hospital readmission reduction program that would penalize hospitals with excessive readmissions for certain diagnoses, heart failure being one of them. In 2014, COPD was added to the list of diagnoses. The readmission rate in 2012 for heart failure nationwide was between 10 and 50%, most of which were avoidable. Although the average was slightly less, the readmission rate for COPD was 20%, most of which were also avoidable. My team for the project are all employees of Independent Health. The team consisted of Dr. Same, Medical Director within the Utilization Management Department, Suzanne Sherwood, Utilization Review Nurse, Arlene Boz, Utilization Review Nurse, Linda Rogowski, RN Case Manager, the Utilization Review Nurse team, the Case Management team, and myself. Dr. Same worked with me in the initial planning phase to discuss changes that could be made to improve quality of care for our members. We also helped in obtaining collaboration between the Utilization Review team and the Case Management team. Suzanne, Arlene, and myself gathered criteria for the high risk for reassessment tool and created the assessment tool. We also did the initial reviews and sent tasks to Linda for follow-up with members deemed high risk for readmission within 30 days of discharge from acute care. Linda performed case management follow-up on members within 72 hours and met with me weekly to discuss issues with the follow-up process. After the initial test of change, we provided the assessment form to the utilization nursing team in my department for use to determine if members were at high risk for readmission, and if so, tasks were sent to the case management for follow-up. The case management team were also included in the process at this time due to the increased amount of referrals sent to case management for follow-up. The aim of my project is to reduce the 30-day readmission rate of independent health Medicare members with the admitting diagnosis of heart failure and chronic obstructive pulmonary disease by 10% or more by December 31st, 2017. The change concept for this project was to assess members for readmission risks during the initial utilization review process and send a task with an attached note alerting the case manager of any follow-up appointments, new medications, and possible educational needs a member may have. The case manager would then make a follow-up phone call to the member within 72 hours after discharge from an acute facility. The case manager would address any stated needs a member may have and any issues she discovers during the phone conversation. Referrals can then be made to community centers for exercise programs and discounted meals. The case manager can also notify the member of any educational classes that may be available that could assist them in staying healthy. Although the utilization nurses have been able to send tasks for case management to follow up before I started this project, there was no criteria to use to assess if a member was at high risk for readmission, and tasks were not being sent on members that could be a potential risk. The first step in the process was deciding what improvements could be made within my workplace that had the potential to improve the quality of patient care and could also potentially create cost savings for independent health. During my reviews over the last year, I noticed that there were several readmissions within 30 days, which could be a quality of care item due to lack of appropriate referral and follow-up after discharge from acute care. The top two readmitting diagnoses for Medicare members were heart failure and COPD, which led me to focusing on these two diagnoses. Reducing readmissions within 30 days would also create cost savings for independent health in all of the facilities in the Buffalo area and the out-of-area facilities also. The second step in the process was creating a high risk for readmission assessment form that could be used by the utilization review nurses during their initial reviews to determine if a member was at risk for readmission within 30 days after discharge. I used elements from the LACE Plus assessment tool and also gathered evidence from other sources to create the criteria for the assessment form my team and I created. Many comorbid conditions were noted to increase risk for readmission, such as diabetes with an A1C more than 10%, renal impairment with increasing blood urea, nitrogen, and creatinine after admission, history of multiple intubations, several emergency room visits within the last 6 months, oxygen saturation less than 90% with a history of home oxygen use, which could be caused by a worsening of their chronic condition. Length of stay was longer than the national average for the admitting diagnosis. Weight loss of 5% or more in a month, or 7.5% or in 3 months. History of MI, stroke, TIA, cardiac stenting, untreated abdominal or thoracic aneurysm, connective tissue diseases, current diagnosis of cancer, diabetes, chronic kidney disease, dementia. Some social issues that could cause a readmission are lack of support after discharge and low socioeconomic status, both of which are noted to cause a decrease in compliance with medication therapies, self-monitoring, and physician follow-up. Independent health members live in various areas over several counties, including Wyoming, Orleans, Niagara, and Erie. Members that live in some parts of Orleans, Niagara, or Wyoming counties have limited access to pharmacies and specialists in their immediate area due to its rural location. There are also fewer hospitals with fewer resources for care. Initial reviews were completed using the assessment form as a guide to identify Medicare members that may be at risk for readmission. A task was sent through the independent health computer system to Linda for follow-up within 72 hours after discharge, with notes attached of any needs the member may have. A message was sent to Linda notifying her when a member was discharged from acute care with a notation of where they were discharged to. Many members are discharged to rehab facilities before discharging to home. Linda contacted members to identify any educational, social, or medical needs a member may have, then address them. After a couple of weeks, we enlisted the help of the entire Utilization Review Department and Case Management Department with the assistance of Dr. Same. This increased the number of members identified and followed up with after discharge, increasing the chances of decreasing the 30-day readmission rate. Some barriers within the process related more to difficulties in follow-up with members. Contact information provided by members was incorrect. If an up-to-date contact information was provided by facilities, we updated it for case management for follow-up. Members refused to speak with the case manager when they were contacted or didn't answer at all. Lack of adequate staff and case management to perform needed follow-ups within 72 hours of discharge from acute care. This was resolved by management hiring more case managers, which gave them the team the ability to follow up within 72 hours with each member that we deemed at high risk for readmission. Some facilitators for the change were the willingness of both teams to collaborate to make this change a success. Case managers within facilities worked with both teams to ensure members had an appropriate discharge plan and also notified our members that a case manager would follow up with them after discharge to improve receptiveness of the members when case management contacted them. Impact on practice. 90% of the members deemed high risk were contacted by case management and needs were addressed, which could decrease the readmission rate with continued use of this process. Other health insurance companies and healthcare facilities can use the assessment form to identify individuals that may be at risk for readmission within 30 days. Identifying individuals at risk for readmission and applying appropriate interventions can prevent readmissions. Hospitals with lower readmission rates have higher patient satisfaction scores. 1,621 hospitals have been penalized every year after the initiation of the nationwide hospital readmission reduction program. That does not include the 1,400 hospitals that are exempt from the penalty that most likely have had excessive admissions also. Penalties of up to $58 million are expected to be issued by the Centers for Medicare and Medicaid this year.